Going to discuss an important issue, which is cataract in patients with keratoconus. We are dealing with patients with cataract as an ophthalmologist, and now we are seeing patients of cataract with keratoconus. How to deal with these patients. I have no financial interest. I would like to thank Dr. Muhammad Ahmed Al-Massry for his help in the preparation of this presentation. So, the guidelines for surgical management of cataract in patients with keratoconus should include three things: the age of the patient, the stability of the cornea, and the stage of keratoconus or, in general, any ectatic disease. The main problem is the intraocular lens calculation and the refractive outcomes in ectatic corneas. First question, is the cornea stable or not? The cornea should be stable before doing the cataract surgery, and this depends on the age. If the patient has an unstable cornea and less than 30 years of age, cross-linking is a must. More than 30 years, it is mostly stable, but there is a debate that we need follow-up on 6 months basis, and there is no need for cross-link except there is progression of the keratoconus. The stability is a must. The size of progression of keratoconus, as we all know: thinning of the cornea more than 10 microns per year, increase of the curvature of the cornea more than 1 diopter per year, increase in the difference between the superior and inferior meridia more than 1.5 diopters per year. The second question is the cornea regular or not regular? In another meaning, can we depend on these K readings for accurate biometry or not? How to make the cornea regular before cataract surgery? Simply intracorneal ring segments combined with cross-linking if there is progressive ectasia. The aim of the rings is to regulate an irregular cornea. So, after corneal stability, we have 5 scenarios. First, mild irregular cornea with Kmax up to 52 diopters. Second, moderate irregular cornea with Kmax between 52 to 62 diopters. Third, intracorneal ring segments are not applicable or the patient cannot afford for it. Fourth, advanced keratoconus. And the last is cataract post-penetrating keratoplasty or DALK. For mild irregular corneas with Kmax up to 52 diopters, which is the first scenario, pentacam is mandatory. K readings and ultrasonic biometry also are essential. Third and fourth generation formulae for IOL calculation, starting by the Haig's L and ending by the Barrett's formula, and all the results should be within 2 diopters of the Haig's L. This is an example of a patient that had moderate keratoconus in his right eye and mild keratoconus in his left eye. Cross-linking and intracorneal segments were implanted for the right eye, and for the left eye just cross-linking, and this improved up to 10 diopters of the irregularities of the cornea with the rings, and thus we can depend on those readings for calculation of the cataract surgery after 3 months of implantation of the rings. This is an example of patient that did cross-linking. He is 32-year-old patient, and the cornea was cross-linked, but astonishingly, after cross-linking, we found this cataract for a 30-year-old patient. The cataract is so hard, and this means that if the riboflavin reached the anterior chamber, it can develop cataract, and the cataract usually is hard because the lens had been cross-linked. As you see here, it needs power, high division of the nucleus with the chopping technique, stop and chop, and then having each half, in spite of being white cataract, but after removal of the epinucleus, you see that half cataract is hard, and so you have to be careful in the history for patients with cataract whether they had cross-linking of their corneas or not, because this may induce this hard cataract. In moderately irregular cornea, Kmax between 52 and 62. As you see here, the patient had rings, and we have to wait for the intracorneal rings for 3 months, then to do pentacam and Haig's L, Masket, Chammas, or Barrett's formula, And as you see here, you cannot depend on an irregular case. It should be regular. The point of doing cataract for patients with intracorneal ring segments is not of high skill. It is the same exactly like the regular cataract. Just be careful of the capsular rexes to be under vision, and after that everything like any other cataract. Be careful of the cornea, protect the corneal endothelium with the visco cohesive material. And as you see here, the lens was a little bit soft, so the vision of the part of the epinucleus was with the visco. And as you see here, the cataract wasn't so hard, so it's about grade 2, and the surgery was relatively straightforward with no tricks or tips for this patient. Postoperatively, as you see here, these are the rings. The patient is pseudophakic and the refraction is -2 and -2, and this is reasonable refraction because all of the time we aim for a myopic refraction for those patients. There is no extra surgical skills. Another patient with intacs, she was glaucomatous, she had infection, one of the intacs had been removed, and she developed cataract. And as you see here, in spite of the nucleus was soft, but it took a long time surgery because the visualization was not so clear. But in spite of that, we gave the patient the chance of doing the surgery, cleaning the posterior capsule as much as we can, and putting the intraocular lens to avoid doing keratoplasty for this patient after assessment of the visual acuity. So we have to wait for this patient after the surgery to assess the vision. The third scenario, intracorneal ring segments are not applicable due to advanced cataract, cannot depend on subjective refraction for ICR design, or the patient cannot afford for the rings, or it's not available. So here we make the surgery on 2 steps. First step, to remove the cataract, then assess the need of the IOL, especially when the powers of the IOLs are out of range. For example, -17 power IOL, -15 power IOL usually are not trustable due to the steep irregular cornea. Here I'm doing the cataract surgery first, leaving the patient aphakic, and to reassess the situation. Second, do subjective refraction when the patient is aphakic. Third, hard contact lens is valuable, and we can assess the IOL need after hard cataract lens, after the hard contact lenses. Fourth, regulate the cornea by the rings if the patient can afford. Lastly, do a secondary IOL piggy bag, or in the sulcus or in the bag, because the antechamber of course is deep. So if there is residual refraction, we can put a secondary IOL. The point of toric IOLs is still debatable. We cannot put a toric IOL for an irregular cornea. So we don't have good results in very irregular corneas, nor do opposite clear corneal incisions or frame to arcuate incisions. All these maneuvers for correction of astigmatism in ectatic corneas or patients with keratoconus usually does not give satisfactory results, because these patients are of high demand. They need to correct most of the astigmatism, but usually here the astigmatism is irregular, and the toric IOLs are not planned to correct an irregular cornea, so preferable to avoid the toric IOLs. For toric IOLs in irregular corneas, only in highly selected patients with stable, mild to moderate keratoconus, with good vision, without corneal scar, and the axis of cylinder on topography, keratometry, IOL master, all of them should be on the same axis, and lens star and refraction must be within few degrees. The fourth scenario is patients with advanced keratoconus. Of course, we know the size of advancement, as I said before, with the pachymetry less than 400 microns and the Kmax more than 62 diopters, endothelial folds or hydrops or opaque apex. Here we do triple procedure, whether deep anterior lamellar keratoplasty, phaco and IOL, or if there is hydrops, we do penetrating keratoplasty, cataract and extraction, and IOL. The fifth scenario is patient after PKP, as you see here. Again, young patient with fungal infection, the usual story. She did PKP, and after a year she had cataract, sutures had been removed, and with the specular microscopy, which is a must to evaluate the corneal endothelium. And we have to fully explain for the patient that the rejection is could happen for these patients because we are intervening with a cornea that shouldn't be touched, and this depends on the endothelium of the cornea. Try to minimize the ultrasound. Try to keep the air bubble all of the time behind the cornea. Try to do the soft shell technique for endothelial protection, and try to avoid the ultrasonic power. This patient had soft cataract, so it had been done irrigation and aspiration. And this is the same patient after 1 day of surgery. To conclude, counseling and complete explanation to the patient is a must. The patient should understand that he has a problem in his cornea, and we should treat this problem before doing the cataract surgery. Adequate preoperative investigations, all plans and tools to protect and stabilize the cornea with which should be regular. Use the least ultrasonic power and give enough time for the compromised cornea to heal. In summary, stabilize the cornea with cross-linking or naturally after the age of 30. Regulate the cornea with rings or hard contact lenses, and may post-IOL implantation to a second session. Always target low myopia. Advanced KC, do triple procedure, and toric IOLs are debatable. Thank you so much.